Good afternoon, everybody. Hope you had a good lunch. Welcome to this symposium on value-based healthcare, sponsored by Air Liquide. A lot has been said about value-based healthcare, but little has been demonstrated about the implementation of value-based healthcare. So today we are going to share with you some examples of real implementation of cases around the patient experience. To have this wonderful event, I'm going to introduce our speakers. So first of all, we have Yolima Cossio, which is the IT Director and Decision Support from Vall University Hospital. We have Maria Gutierrez San Miguel, which is the Process Unit Coordinator of the same hospital. And on the screen in remote, we have Maria Belén Lopez, which is the Business Development Manager of Air Liquide Healthcare. In a moment, you are going to also discover her. My name is Carolina Aguilar, and I'm the moderator for this session. So the title is about a real patient-centric approach, as I'm saying. And at the beginning, we are going to have a conversation about what is value-based healthcare. And actually, that is the first question. What is value-based healthcare? And I will ask also in this room to raise your hand if you think you are familiar with the concept of value-based healthcare. So can you raise your hand if you have heard, worked, or implemented value-based healthcare? Great. So you are going to then be very familiar about this equation, the infamous Porter and Teisberg equation, which is value is equal outcomes that matter to patient, right? This is very important, divided by the cost of the delivery. Now, what is the difference with what we normally have in our healthcare systems, which is more a volume-based approach, right? And here we try to depict actually those differences. Volume is more about a fee per service. There are no rewards for quality or outcomes, and there's not a lot of collaboration and IT coordination. Whereas value is about payment to manage populations, incentives and penalties for quality outcomes, so very important quality, it is rewarded or penalized if it's not there, shared accountabilities, and IT and data as key enablers. We are all going to be patients at what time or at some point in life. So working with transparency and with data, it's going to be key for the future sustainability of our healthcare systems and of healthcare in general. So I'm going back to my place, and we are going to have a conversation about this. And the first question is going to be, what is in it for us? Why should we implement value-based healthcare initiatives? Let's see if we can get Belén, and we start the conversation. So, Yolima, what is in it for us?
Thank you very much. Could you hear me properly? A little bit with a cold, but don't worry, there's no COVID at all. Then get relaxed. So it's quite an interesting question. Why value-based healthcare? I think that all of us has been patient or will be a patient. Then the first thing when you are a patient is, I want to recover my health. And it is quite a contrast with what happened with the healthcare providers, with the regulatory agency, and with the rest of the stakeholder of the system. Because all of us are thinking in different outcomes, but not specifically in this one, that is the objective of the healthcare. So, for example, if I have a fracture, a hip fracture, all what I want is to walk again and recover my life, as simple like that. But, for example, the healthcare provider could be concentrate in if efficient the surgery, if the patient will stay short term in the hospital, if they get paid for the waiting list, or for another kind of outcomes that are valuable, are important, but not exactly what we are focusing, what we have to be focused on is in the recovery of the health of the patient. So I think that this approach of be focused in this kind of outcomes, what really allow us is to concentrate in the same objective. It's like, don't speak about different things. So if all of us will have the focus in this outcome that matter to the patient, the other outcomes will come. So as you see in the question, cost will improve. For example, the waiting list will improve. The other processed outcomes also will be better because the final outcome is achieved. Then basically, as a healthcare providers, we work for a long time focusing in other indicators, but I think that now is the time that we see what is the best option for the patient. To have these outcomes also will allow us to have a conversation in the room with the patient about what do you prefer, how do you want this treatment, how we can help you to recover your life. So as a clinical providers also give us this tool to have better conversation with the patient to improve the health, and also to compare and to see if what we are doing is the best option. Then it's also help to improve and develop new innovation that result in better outcomes. Then basically I think that the why is very clear, is because we focus in many other things, and now is the opportunity to be concentrating what is really important for the system, for the patient, and for the clinical provider, for all the ecosystem basically of the healthcare.
Yeah, and this is fantastic to hear, because when I work in the diabetes clinics that you are going to know a little bit about a bit later, a lot of people, the first time we were going to implement value-based healthcare is about there's no money to do it. But as you said, when you work on the outcomes, the cost gets fixed, right? I mean, and the equation is so simple that people don't really pay attention to it because it's really simple, but it's actually quite complex because you have to make this numerator and denominator work. And there's always a relationship between them, right? So you always find the money to do that if you work on the outcomes. That's also my personal experience. So it's very interesting to see that from a provider perspective. And now I'm going to ask Maria Belén in remote about the industry experience. So what is in it for us also as a partner in the delivery of healthcare?
Hello, everyone. I hope you hear me okay. So the question, Catarina, is that, well, what is in it for the industry? Sometimes in this industry, we have a role to play, and how can we play this role? It's kind of tricky to answer. So I want to tell you about Air Liquide, which most of you know because we are in the provision of medical gases to hospitals around the world. But we also provide medical devices in the patient homes, which of course let us have a unique place in the patient's care journey. So over the years I have working in this company, I had many times the opportunity to go out in the field in different countries and see the amazing work our teams are doing, being there for the patients in a place, if you can imagine, as intimate as your own home, sometimes bringing these devices in your own bedroom. And talking to all of these amazing professionals, you hear all these stories about the patients that sometimes they need extra support or some counseling or some reassuring, or I mean, sometimes they have these diseases and they are kind of lost. And they need this extra support, which is actually the human side of care. But of course, in a free-for-service world, this is not recognized or even measured. So in the free-for-service world, as Carolina was talking before, with all the volume, we look for more patient intervention in lesser time, looking for numbers and performance indicators, counting the minutes spent per every patient, which is contrary to this notion of value we want to do when we are working in healthcare. And for me, that unique moment that the nurses working in Air Liquide said they are going to take the necessary time And I always like to make emphasis on this word, the necessary, meaning no more, no less, to see into the patient's unique need and accompany them through the process in which they are in need at that moment. And this is why for us in the industry, and Air Liquide, which has this really unique place, being this link between the hospital and the home and everything that's in between, that the transformation towards value-based healthcare has so much appealing to us because we have everything to gain with caring with these patients and showing this value of having this outcome for the patient, this solution extra for the patient, and measuring these outcomes and these results, not just by numbers, but by really what the patient is feeling, creating, being able to use the therapy we are bringing to their homes, and really create those value creation loops that are leading to transformation.
Thank you, Maria Belén. And what you say is so relevant because we are at a congress that focuses on the future of hospitals, right? And I was reading an article recently about this Qatar hospital that is being built over one floor only with thousands of square meters, highly digitalized. But is that the answer to being a patient, and especially a chronic patient? And this intimacy with your home when you are a chronic patient needs to be included in the equation, and then quality and outcomes from the hospital to the home care need to be preserved, right? So how do we make that happen is also a big question mark, and their data and outcomes, of course, are also a big driver. So that takes us into our next question. I don't know if we can project it, but otherwise, the second question for you all is, what are the barriers and opportunities in adopting value-based healthcare? And this time I'm going to start by Maria.
Okay, thank you. Can you hear me well? Yes, I think. Well, that's a very good question, because we've been hearing for a while already value-based healthcare, the terms. There have been shy tries, there have been not that shy tries either, right, as well. But it seems like it takes a lot to implement, right? When you go to a team, yeah, we're going to implement value-based healthcare, you get asked so many questions. I think the first, maybe a barrier is good communication, because not everybody knows what it is, and that's a fact. Some people, think it's about just cost. Some people, yeah, it's about outcomes. Some it's don't give me another thing to do because I have already so overcrowded the agenda and I really cannot do anything else, on my daily basis because it's already so full. We have many interactions with the clinicians. So I think the first barrier that we really need to, solve is the communication of the term, and we need to agree what it is among us. Value, because it's not that simple, right? No. As well, give me more, okay, I'm really interested in the idea, but give me more resources, for example. Mm-hmm. Or what's going to be the cost for this? Because I'm really interested. I really see, the intention, and I'm really interested in this should be this way because it's all patient-centered. But give me the resources, how are you going to do this? And I think, the main barrier, that sums it all, it may be the cultural change that lies, behind anything that under the umbrella of the concept of value-based healthcare. It's the cultural change at all levels. This cultural change is not that easy, right? It's just about change management, and we all know here, change management is a pretty tough thing to deal with. So, yeah, I'd say that the main barrier is cultural change, at any concept that lies under the umbrella of value-based healthcare. We internally have, we've been trying to implement value-based healthcare, and we've been developing a methodology, a blueprint for this, because it's, we've been trying with some clinical pathways, and I've seen different cultures within the same hospital. So really, the thing to get approached this is really to adapt the methodology to the group that you have in front of you, because if the clinicians that are, on the front line, that treating the patients, do not understand or do not know, or they are not going to use it on a daily basis. So you really need to approach this cultural change really adapted to the people that you were working with in that clinical pathway. So I don't know, maybe I'm going to explain a little bit the methodology, or do you want, okay. So, so this methodology that we have consists, like, it's a pretty big one. Like, you know, it interacts with all the levels of the hierarchy levels of the hospital, but it's centered with, above all, on the people that is on the front line, you know, the people treating the patients. So the first thing that we do is first we select the clinical pathway that we want to work on. So by doing this, we need to, you know, there are some algorithms behind this choosing fact that we have, because leadership needs to be there for sure. And leadership, you know, among all the profiles in the hospital, leadership in nurses, leadership in doctors, leadership in administration people. We really, really need leadership, because change is going to take some tough decisions, you know, some resistances. It's going to raise up a lot of these things. So we really need leaderships, and this leadership needs to be, you know, on the front line with the clinicians.
Yeah,
right?
and if I might something, always involve your CFO, even if the CEO is in agreement, right?
Exactly.
I don't know if that is your experience,
Yeah, for sure.
but always the first to come on the table, don't ever forget about it.
Yes, the CFO and the CEO, I'd say as well,
Yeah,
because like there's not, I mean, this clinical lead that we're gonna have, they really need this to rely on, you know, that he's gonna have or she's gonna have the support for these changes that they're gonna be pushing, right, and convincing to all the people. We all know that in any working group there are gonna be like early adopters that, you know, like this, they're gonna adopt the change and they're gonna be super, you know, funny about this, but also there are gonna be some detractors as well. And also there's going to be those in-between people that, you know, by one, we need, you know, to bring it on. So, yeah, like I'd say CEO, CFO, you know, and the clinical leadership above all. Second of all, what we do is we balance the state of art of that unit. And this is very important, because the state of art, you can assume what it is. We have some indicators. We have, you know, some, you know, safety complications. We have we may have data, but the culture that there's in the place, I don't know if there's that much data about it, because it's a cultural thing. I wouldn't say it's intangible, right? Mm-hmm. So we have this structured interview with the clinical leads, you know, to ensure a little bit of the culture of the place. And also, as well, we have this questionnaire, the culture of care, that we want to, you know, quantify a little bit, you know, the culture of the place. So we have, you know, objective data about it. So once this pathway and the leadership is chosen, we then get to, you know, form this working group. And this working group is more extensive. So we have clinical pathways, like for stroke, for example. We're going to talk about this later, but it was like 30 people in the working group, for example. But all profiles need to be there. Like there's no profile that can feel excluded, and that's very important, because whoever is excluded, then that's gonna, you know, come up as resistances later on when the implementation comes. So every profile that touches one patient of that clinical pathway needs to be there, and that's very, very important. It may be like super large groups, or some other clinical pathways are, you know, small groups, but they need to be there, and I'd say that that's a pretty good point. Later on, we have this training session for them, because about value-based healthcare, because not everybody knows, everybody knows, but they don't have the same concept, so we need to agree on what it is. So this training session also is very important, because it's like a playful role-playing session. So we need to identify the leaders, because one thing is the clinical lead that you've, you know, that's a Tyler, you are going to be the leader, but then there are so many personalities in the group. And you have the leader in the you know, in the shade. You know, I'm very shy, but you know, they go one person by one person, convincing the other one. So they are also leaders. I mean, you have so many personalities in one group. You have resistances. You have, you know, past experiences that don't come up until, you know, some 1 month working in a group. So you really need to, you know, try to focus on the personalities in the group, because you need to adapt the cultural change to those personalities. So this training session, apart from, you know, giving them the concepts of value-based healthcare, of course, is to know to spot all kind of personalities in the group. Later on,
in the good sense.
Of course, always in a good sense. Yes. Also, yeah. People are very keen on you know, having this implemented. Yes. They want value-based healthcare. Like, they've heard about it. Like, now it's starting, you know, in the research field. They want that. Just that they don't know how to adapt their daily basis on that. So it needs methodology for this. And of course, in the good sense, yeah, because
I'm kidding.
Yes, clinical, I mean, it's a very vocational work, so everybody is there for the patient. So it's just about methodology, about changing. Later on, we map the process. And that's one key point, because when you map the process and identify whatever brings value to the patient and whatever doesn't bring value to the patient, it's a very important conversation that needs to happen because it's not agreed. Like, it needs to be from the patient point of view, not from the clinician point of view. It's from the patient point of view. So there are many tasks that patients don't even see. So we don't talk about those tasks. We just talk about what patient sees. So we focus on the patient. And and sometimes it happens, like, because we are very, silo, structured in a hospital, so that communication is not that fluent. It's not that fluent. So it may be different floors, it may be different buildings. So they don't even, they write on the same clinical, records, but they may not know each other.
Yes.
So it's important for them to define value from the patient point of view within that group. So, and that's what we bring up in those mapping sessions. We have also, once they've heard all the non-value that comes up in that, by the way, I'm gonna say it later, but the non-value tasks, there are some methodologies that are controversial when applied to the health field, but it looks to us like when we've been trying on the field that it's pretty much like this. Like, it may be quantified like the 50% of our time. 50% of our time we're working on some task that is not gonna bring value from the patient point of view. We're doing stuff. I'm sure it's like it's in every hospital the same. Like, people work super hard, very hard. It doesn't say that what we are doing gets to the patient in a value shape. It means, right? It's like we work very hard, and I'm sure it's the same for everybody, right? Like, people go.
No, but that's key to identify, right? Because those are the question marks that you could even delete from your pathway, and where cost might be safe.
That's
right. You always have to find something you are not going to do.
Exactly.
That's focus.
Exactly. That's focus. Like, how many times physicians need to go to the MRI to reclaim that test that he's prescribed, or how many suspensions in ORs are there, or how many. There are so much non-value tasks that people work very hard on them. It just like it doesn't get with the shape of value from the patient point of view. That's very important when mapping is to be from the patient point of view, because with that you detect all those things. You detect all the non-value, and that's really very important. Also, they hear all the non-value that the coworker has because it may be consequences. It's all in a chain, like what I do may come up as a non-value to the coworker, and I don't even know about it. So when you map all the process, it's like you hear from all the profiles that touch that patient, all the non-value. So it's common then. Later on, we have this observation crossed profile, because it's not, it's very important that they hear the non-value from the other coworker, but they need to experience it as well. So we cross them, and they observe each other. Doctors observe nurses, nurses observe administration people from the administration observe porters, for example. We cross them all so that they get to experience what the non-value is from that coworker point of view.
That's really important.
Because we need to get process fluent. I don't know if that rings a bell among the audience, but it's really important for them to understand all the care process from everybody's point of view, from the patient point of view, not just what I do with that patient, what everybody does with that patient. Afterwards with that, when we've really seen all the non-value in the care process, that's when we draw the new standard. That's how we want to work. We're not working like this. We want to be value-based process, right? So when we draw the process that we want to be in, we delete all the non-value tasks, all the waiting times, all the indicators that make me work towards quantity-based instead of value-based, right? We detect all those things and we draw a new map, value-based. And then comes a session that I really want to emphasize, because it comes with a session with the patients. And that's magic, really. That becomes magic, and I'm really enthusiastic about it, because that's when patients tell what value is. We've been, talking a lot among each other on value. We've been, like, many problems have come up, but we haven't asked the patient yet. So when patients come in and you ask them what value is, we get so many things. And that's really, eye-opening. Because we tend to think that when patients come in, they're going to tell us about the infrastructure problems that we have or technology problems that we have. And yes, we have them, but patients don't talk that much about it, right? You've been some of them. They talk about information, communication, non-value like waiting suspension times. They talked about this. And they talk about what she was saying, right? The thing that worries me the most is how hard it is going to be this on me.
So what happen at home?
Yes.
How I will go back to work.
Like what adds me value is to leave all of this, right? I have to live through all of this, but I want to leave it at home. And that's what I want. And that's going to bring value to me. I know it's more comfortable for you and for me to be here, but it's not what I want. And they tell you that. Yeah. They tell you that. Or I don't know, I can tell you so many examples. I don't know, because I don't want, to take that much time. But I don't know, ostomies, for example. Like, people were saying that we need information about going to the beach. Really, yes. That's what I'm worried about. Oh, sorry, that's what I'm worried about. Yeah. Right? Hemophilia parents told us that they want to stop being ambulances. They want to be parents. Right? They need the information to treat. People, they are the best. Like, and I think this is just the beginning. That's the neighbor, right? The opportunity is embarrassed. That's the opportunity with us. We don't need to work for the patients. We need to work with the patients. Yeah. Because they tell us that. They tell us what value is, and that's when the term personalized medicine comes in. Yeah. Because value is different from each and every patient, even with the same clinical pathway.
And it seems rather simple, but you had to find that methodology, refine it, and see what works for you, because it seems logical, right? But I know it's not that simple. Indeed.
No. Many resistances come up, right? Because when you say non-value, it's non-value from a patient.
It's a threat. It's a threat, of course.
But it's a threat because, I care about this task that I've been doing for 30 years so much, and I do it very well, and with all my vocation and with all my best interest. It's not like, but it's just non-value from the patient point of view. So we need to migrate that. And many resistances come up when these sessions really, like each session maybe take 3 hours, something like that. So the CFO comes in because it's so many hours from everybody.
I know.
But it's really necessary to find that common ground.
Thank you for sharing this with us. I think it's very important and revealing that everybody knows that there's people, working on methodologies that actually work, and we will see later data, right? That's why you come here. But Yolima, what do you think about the topic?
Listen to Maria, many ideas come to my mind, and I want to ask the same question that you did before. You raise your hand about did you familiarize with the concept of value-based healthcare, but I also want to know how many of you have tried to implement value-based healthcare in your organizations. Could you raise your hands, please?
Okay, so awareness, there's a lot, but implementation, a lot less.
Yes, it's the second step. And how many of you has been successful so far?
Okay.
Good, fantastic. Okay. Well, I want to know if you familiarize with the idea why you don't go to the second step, why you don't start implementation. And once you start implementation, what you consider that is successful or not. Then all this process that we were working in Valdebrón for these last 3 years in the implementation come to my mind, and it's basically, the theory, you think that it works, it sounds fantastic, but how do we start? I think that this is the first barrier. Who will start? As a manager of the hospital, you think how this concept start? Is the regulators who will start to pay to us for the outcomes? Or is our clinician who start to ask, hey, we want to implement, we want to collect outcomes, and we are in the middle. We are managers, we are CEOs, then what we wait for? We wait for the leadership from our company, or we wait for these regulators, for this agency that pay to us, tell us now is the moment. And then I think that we need to find a balance, and I think that the role of all the CEOs and the managers is exactly that, is to find this middle point of the conversation between the leadership of our organizations, but also with the big to see the big picture and convince the regulators that this is the way as well. So when we start to convince the CEO that, well, it's a long story, but to make that short, the first question is, okay, could you prove that it will reduce the cost in a short term? And it's one of the big barriers, because the concept of value-based healthcare work, you take into account all the process of the patient. And this work in silos of our healthcare system is what don't allow in the short term to see this thing. So we need to do methodologies, as Maria explained very well, of improve the process in the pathways to show that there are results, because if we wait to implement in all the system, it will take such a long time to see really the result of all the equation. Then the barrier is that the manager, the CEO, want to see result, but we cannot see the result of all the big picture until we have primary care and all the provider on board all this implementation. So we need to establish a strategy in our organization that helps us to see result in the short term. This is one of the first things.
Just a point there. I got that question all around the globe. And I came with an answer after so many trips and so many thoughts, which is, would it be worth also to have the same cost at the double the outcomes, right? Like, people are obsessed with decreasing cost, but sometimes you don't have to decrease cost. It's very difficult to decrease cost. The same cost with double the outcomes would be phenomenal already, right? So I would say that people shouldn't be obsessed about decreasing cost, but really obsessed about increasing outcomes. Right?
Yeah, it will be lovely, yes. Yeah, that it will be what we have to be focusing. Also, what is the cost that we put into the equation? Because many times we just see the economic part of view. That is another barrier. It's difficult to find the denominator of this equation in some organizations that we don't work for charging every specific patient. So it is difficult, but what about the other costs? The cost for the entire system, the cost for a person to be on leave because he's sick, the cost for the personal life of the person. It's difficult to quantify all this, and then it's a barrier to show that it really works, because we can't know, or so far it's hard to demonstrate and to put into the equation all these other costs as well. But I think that we need to put this cost in the equation. Speaking about the barriers, I'm from the IT department, so I don't want that you raise your hands at this question, but how many times do you find that you want to implement value-based healthcare and you go to IT department and say, what? And we're so busy doing other things. Please don't raise your hands. So, and in the same way, how many times do you go to the economic department and say, we need to see what is the cost of this patient of the pipeline for, I'm so busy doing another things. And I can continue it. Then one important thing is that if the CEO is convinced, if all the support departments are convinced, then we can have all the support to implement that, because the clinical team cannot do that alone. So to have a core team that help with the implementation, and this core team, you have to have communication, you have to have process, you have to have IT, and all these departments that will leverage all this implementation. They have to be on board. But for them to be on board, it's not because they are a good person and they're going to help us. No, it's because value-based healthcare is in the strategic plan of the organization. It has to be in the agenda of the organization, and when the executive committee had meeting, they have to discuss about values-based healthcare. They cannot discuss about other many things, and because if it's not in the agenda, it won't be in the agenda in the other support other support team. Then basically, to tackle all these barriers, one important thing is that as a manager, as a CEO, you be convinced that this is strategic for your organization. If not, it could be implemented, but it will be so hard for the clinician to do that. Otherwise, it could be implemented for the regulators that one day come and say, we're going to pay you for the results, But when they come to the clinician, when they come to the patient, they won't understand what they come with that. Then it will be completely rejected. It will create antibodies. And at the end, not many people will answer the patient report outcomes or anything because they don't understand what they're doing that. Again, these people that pay that don't know that we're so busy doing other things, important things. Then this is my point of view. Implementation is good if we, as a manager, as a CEOs, are convinced that this is the way.
Yeah, a lot of wisdom there, I see. Let's ask also Maria Belén, very briefly, because we have to continue. What do you think are some of the opportunities and barriers in the adoption of value-based healthcare?
So I'm gonna go with the biggest opportunity, I think, is that value-based healthcare opens the notion of value that we all agree into. So then it becomes really interesting to create those partnerships that start not just working in the hospital, in different services of bringing the care to the patient, but really on the patient, wherever he is, like they say, every time, when they need it, how they need it, etc. And a huge opportunity is for all of us to find a common language, to start working together for bringing these outcomes, eliminating the redundance of sometimes of care that happens because communication and coordination is not working correctly because we don't agree in the same results that we want to measure. So for me, is one of the huge opportunities of value-based healthcare, and I'm not going to go too long into it because I'm going to respect the time, Carolina. It's just this huge opportunity of having a common language and then creating value with multiple actors throughout the industry, the healthcare industry, hospitals, primary care, home care services, the pharma, the medtechs, everyone in the industry.
Thank you, Maria Belén. And this is why the case of Valebron, and again, we are going to know more about it, is so exciting because it is 360 collaboration. And you see there's an IT department that is being briefed in value-based healthcare and it's supporting value-based healthcare. There is a pathway process coordinator. The CEO is involved. The CFO is involved. I mean, there's support all around. And not only that, you have written an implementation blueprint. I mean, it's a publication with more collaborators on how to implement this in hospitals. And we have a slide on that, so I don't know if we can project that. My dear IT support. Let me see. We can, I cannot pass the slides now. Here it is, yeah? So that's been published in Value in Health, right, recently?
Yes, yeah. Well, we are working in a group with the 9th European hospital, university hospital that provide specialized care like Karolinska, Leuven, Vienna, 9 of them, yeah, some of them. Then all of them have a department or a people that are implementing that. Then we meet with them, we exchange experience done from all these meetings and all these experience of these different hospitals. We wrote this consent about what would we think that is, or what are the steps to implement from the management point of view to implement values-based healthcare. So yesterday or 2 days before, they confirmed that it will be published in Value in Health. So I think that in the next edition, it will be available. If you want to know more about that, then you can go to the article. That is also it's not here. This is a summarized picture, but also there is a discussion about what are the barriers and how could we tackle these barriers in this article. Then I invite you to read that and to contact us if you have any questions.
Congratulations, and also for that collaboration outside Catalonia, outside Spain, because it's happening everywhere, right? We have speakers here from Australia, from US. At some point, there has to be also agreement between all these partners to make this scalable, right? And benchmark, being able to benchmark. Yeah, that's also another magic word. All right, so as part of the implementation, we want to let you know about some success stories that people are tracking around Europe and around the world. In this case, around Europe, many of you might know EIT Health, and they have been working on a great framework, which is called the EIT Health Value-Based Healthcare Implementation Book, which is free and available to everybody. And there's where you can discover some of the case studies that are considered a success when implementing and not only talking about value-based healthcare. So you have Santeon, the infamous Martini Clinic on prostate cancer, Diabetes, which has been very close to my heart because I led the expansion of the clinics in the Netherlands and in Saudi Arabia and other countries. So we are going to discover a little bit more Diabetes, but you have also Basel, Karolinska, etc. So I welcome you to take a look to the report and to the framework. And now we are going to discover just one of these cases on the Diabetes type 1 diabetes clinics.
Diabetes is what we call an integrated practice unit, and we can take our own decisions, how many nurses, what we do in technology, in order to provide the best possible care to add most value for the patients.
With the doctors, the nurses, the dietitian, psychologist, I think that's the power of the team.
It has all the services and all the benefits of a good hospital in the Netherlands, but it doesn't feel like a hospital for the children and also for their parents.
Here I know they can help me, and I know that they will do anything they can do for you to help you with it.
In between the visits, they use the system to upload their devices. They get a report back in 5 minutes, and you can see how you improve and how you deteriorate. And offering this kind of IT loop improves the care tremendously.
In these days, we see them grow, their weight is coming back, but also they grow in their confidence. They know how to deal with this disease, and that's a very, very beautiful job.
They give you the trust that you can manage your own disease and that you're not alone.
The way we do it, the value-based healthcare, the environment, it means that better outcomes result in better lives, in longer lives, and in healthier lives. And that's a very good feeling.
All right, so it won the Value-Based Healthcare Prize in Europe in 2017, and it's about empowering the patient. So the patient is always at the center. You see there is not doctors with codes. The philosophy is about you come several times per year to the clinics, but the rest you're at home, right? We are the 1% that supports you, but 99% of the rest of the time is you, and we are going to support you wherever you are, right? So there is a dashboard that shows the last 24 hours and the last 3 weeks in color-coded for the patients when they upload their results on diabetes, and they can see the colors, because patients don't understand numbers, or it takes more effort. But if you see you are green, you are happy, you have to continue doing what you are doing because you are good. But if you are going into a hypo or a hyper, those values become blue or red, right? And then is where you receive an advice about what to do. Actually, usually diabetes patients, they go to their hospitals about 4 times per year. In diabetes, there's 28 touch points throughout the year. So you might think, oh, that's more expensive because you have to be in contact with the patient 28 times instead of 4. But actually, those touch points are cheap because they are very value added, but very cheap in cost because it's digital touch points, right? So it's all cloud-based monitoring. So that's why diabetes became a Harvard Business School case and got the Value-Based Healthcare Prize. But not only that, it convinced through the outcomes that were far superior than the rest of the average in the hospitals in the Netherlands to actually engage with the biggest insurance company for a 10-year bundle payment, right? So there was a negotiation with this insurance company, and David now has for 10 years a bundle payment, so a price per patient per year, where they can choose whatever treatment is the best for the patient. Then if the outcomes at the end of the year are better than the previous year or equal, they get a bonus. And if those outcomes are worse, they had to pay a penalty, right? So that is shared accountability. If we keep helping these patients in the good direction, because we are saving money to the healthcare system, then we split, right? You give me a part because I help the healthcare system saving money. But if I don't do a good job, and actually that patient is worse at the end of that year, I don't have to pay a penalty because it didn't work, right? So that is about sharing the success and focusing on the outcomes, and of course payment needs to come with it. So this is the dashboard that the EIT Health implementation book created, where you can see the different areas. And Diabetes has scorecards, of course, like Santeon and all the other players in value-based healthcare. Of course, data is very important. There is an IT platform that actually helps the connectivity of all these devices. So the only, let's say, deal breaker for Diabetes is not connectivity to a provider. So we were always asking, can you connect to the cloud? And if they will say yes, okay, you are welcome. If they say no, sorry, we cannot take you, right? Of course, patient pathways. I mean, imagine we had 5 clinics in the Netherlands, then we had to expand to Saudi Arabia, very different country, very different pathways. And outcomes need to be the same or better, right? So we had to map all these patient pathways, understand which value steps make sense or not, and then when you move from center to center, outcomes need to be benchmarked and equal. You cannot have a clinic with wonderful outcomes and the next one with not such a good outcomes, and you cannot go to Saudi Arabia and also not have those wonderful outcomes that we have in Netherlands, right? So all that is about patient pathway mapping and a very careful approach to how to create the outcomes and how to benchmark those outcomes. So anyway, if you want to know more, it's a great example. I've been very honored and proud to have participated on that. And now there's wonderful people taking it to the next level. And talking to the next level, another example that is on the Value-Based Healthcare implementation book is actually Valdebron. So we thought that we will bring you those success stories with deeper roots to you here. And Maria is going to start with the first part. And I will give you, yes, thank you.
Okay, change of a scenario. Okay, so we've been talking about value-based healthcare, like some hands were raised here, right, about trying to implement. Stroke was one of our first clinical pathways that we worked on. And there was a strong clinical leadership. There was a very implicated team. But yeah, that's the thing. We all knew, right, the concepts behind it, but how do we make it land? Because we're a 9,000 hospital staff. So, right, communication is a key point, but how do you get that information to 9,000 people? So that was the thing, right? We wanted to get it to we wanted to get to all the clinical teams, so we applied that methodology, clinical pathway per clinical pathway. Stroke was one of them. So we worked in 3 areas. Like, first of all, as Yolima said, organizational change. That was a key point. Like, we work in 3 spheres: organizational change from the board. All the boards, like the CEO and all the support boards, directors need to be there. We all need to be there. There needs to be an agreement, like, at all levels. Also, we had to change the way we work. Like, as clinicians, we're very used, to go to the evidence to find the best clinical solution. But we're not that used to getting to the best methodology, evidence-based methodology for the organizational problems. So we need to change the way we work as for the organization problems. And also we need to change the relationship with the patients. We work in this triple approach, all to get to this famous equation, right? So when it comes to the triple approach, as I said before, and we all have said before, we need to approach it, and it's okay, we have the A3, the tag time, prom sprints. We all know the technical part of it, but we need to approach it, from the right side of the brain. Resistances, fears, expectations. I've heard that. I've heard this. We need to approach from the right side of the brain, not from the left. Left are just tools. Right? It's what's going to make it work or not. So, as we said, the first approach was the organizational change. As we said before, traditionally, hospitals are organized, by silos. There's the ER and the outpatient clinic, the inpatient clinic, the ORs, and they have the KPIs, they have, the teams, each of them, they are, silo-based. But the patients, keep on circulating among us. And that's what really it's about value-based healthcare, because between those silos, there's a lot of non-value, accumulated non-value. So we really need to change. So we change into the areas of knowledge. So there's, this area of, neuroscience, the area of the heart, the area of, by knowledge. So the clinical teams is just one per area of knowledge. Of course, there's specialties, of course. I thought you were raising. So of course there's, the clinical team per, area of knowledge. KPI are common. So we need to, build up already the team so we can break the silos. And also there's this methodology. That's the methodology we were talking about. There's this methodology, each color that you see is a different direction. The direction of IT, direction of communication, direction of quality, direction, and every finance, of course. Each color is a different direction, so all the directions are in there. Each column is a space, is when. When do I do this? The start, next week, in 2 weeks, right? Then who does that, when, what we do. All is written down. Everybody knows when to access, the team so that we can work it successfully. And also we need to change the relationship with the patient. We bring on patients, we bring those in and we do this journey map. So when we map the process and they tell us the highs and the lows emotionally. I was and it comes up anytime. With the breast cancer patients told us one of the saddest moments was when we discharged the patient, because they felt completely, uncontrolled. They were used to being controlled, month per month, and they were used to being that, controlled like that. So when we discharge them, they feel like too soon, too quick, right? So when you map the journey and they tell us when and what, that's very interesting. We also do this map of empathy map. The empathy map is what I hear, what I see, what I listen, what I say, what I do. The people tell us all the time when they are at home, for sure. When they are at home is what they speak about the most. I hear that, I think that. So that's the way we can help them. And so the stroke case, I'm going to talk about a little bit. This is what I was talking about. A little bit of the concept. Value-based in process means that we can characterize the task in three options. We have the value, and that's what patients need to tell us what value is. But mostly is what the patient has come to the hospital for. It may be an education, it may be a treatment, it would be a diagnosis, whatever the patient has come to the hospital for. Hospital or any health institution, actually. There's also the non-added value, and I think we are going to all agree about this, right? The suspension in the OR, the waiting times, the waiting list that Yolima was talking about before, all these things that don't bring value to the patient. And we have the in-between, and we could talk about this forever, but what it's most importantly, numbers are not that clear in the evidence, but they point to this direction. And I'm going to ask, do you feel like this can talk about in your hospitals, in your institutions, Does it look like it? Right? Yes, here. Because there are so many times, there's so much time that we use for the non-value task, not because it's not anybody's guilt, it's not anybody's fault, it's not about that. It's because the pathways that we have implemented in our hospitals, submit us in these routines. Like nobody wants to suspend the patient from the OR, nobody wants it, but the pathways that we have within the hospital makes us do it. And everybody is really not happy about this. And there's like a 50% here. So when we talk about value-based in the pathways, it's about 50% of improvement here. So, and they are all going to focus in the PREMS, any kind of outcome result from the patient point of view. Because, suspensions bring complications, waiting lists bring complications. Everybody, right? All the non-value brings bad outcomes or worse outcomes, right? And so, adding the top of the top, in the non-value, there's the safety errors, and that we need to focus on, because that's really not, we cannot allow this. And so, we built this working group in the stroke, and it was like 30 people because patient kept on going through many units within the hospital, and I'm sure it does like in your institutions as well. We mapped the process. All the pink ones are the non-value stuff. The pink ones that you can, some of them, right? Those were the things that the clinicians were bringing up, right? Waiting times, miscommunications, all that stuff, the pink ones. Then we did that observation, we crossed that observation, this is a spaghetti chart. The chart up above brings the interruptions. Interruptions is a non-value source. Interruptions means unstructured team communication, and means safety errors, means a lot of, things that make worsen the outcome. So this is a crucial thing. Observation, clinicians experience the non-value that other clinicians feel when they are with the patient. This is the new standard, when, who, what we do in each timeline of the day, and all the outcomes that come within that timeline, right? And so this is what came up when implementation. It came up from the coordination with the, agenda, because so many people were interacting with the patients that they kept on stepping on each other. Oh no, this is physiotherapy time, now we cannot do that test, right? So everybody was revolving around the agenda, primary care, right? Training session with dysphagia, because the tests were being interpreted differently from unit to unit. Physiotherapy within the first 24 hours already, home follow-up. Patients kept on telling they wanted home follow-up, and all these kind of things. This is where they agreed that would bring more value to the patient, so this is when implementation came. And this is a thing that I want to talk about. This was the session with the patients. There was this woman, and that really, she spoke like transparently. So she said, and you could see that because this session is brought, with the clinicians, they are in the room, but they sit, without the white coats. Patients don't see them; they are backwards, right, at the back of the room. They don't see them. So when patients come in and we, do this journey map, this empathy map, there was this woman who had stroke. And this stroke, really, it was like nothing, because she could talk, you couldn't even see that she had a stroke. But she told us, yeah, well, I had a stroke, then I went to the hospital, thank you so much, because you're heroes, almost like you treated me very well. But when it came to the discharge moment, you told me to go to the primary care because I had to quit smoking. And you could see the clinicians, nodding, because it's obviously, right? It was really with the relationship with what happened. So she went to the primary care, and they gave her the treatment to quit smoking. And some time into the treatment, she felt some palpitations, so she went to the hospital because she thought that she was having a heart attack. And at the hospital, they told us, no, it's not a heart attack. You need to go back to the primary care because you need to change the treatment, because those palpitations are related to the treatment. So they changed the treatment. And I don't remember the symptom, but something didn't work either. So she came back to the hospital, and we told them again, go back to primary care because it's a treatment. And so she spoke like literally like this, because of how you are organized, it is so difficult to do what I'm told to do. And that was eye-opening because, yes, we had a good needle, door needle time, but, in the not that acute phase, we needed to improve a lot. And patients tell you that. It's not the CEO, it's nobody in the white coat. It's a patient telling you need to improve how you're organized. And that's eye-opening, that's cultural changing. So, and this is the board for the continuous improvement, right? We have some referees for each tasks, and of course, everything that the patient comes in and tell us is incorporated so that we can move on to the dashboard and continuous improvement. At that point, that's when prompts come in, right? And that Yolima is going to talk about this. I just wanted to say that some, very top learnings have been the full support of the board, as Yolima said before. Nothing can, this does not happen if the board and all the support directions are not into this. It needs to be bottom-up. Clinicians need to lead this. It needs to be everything from the patient point of view. Also, it needs to be right brain guided rather than left. The continuous improvement, that's the most difficult to get, because when you're working on something, but when you stop, it needs to, the wheel needs to be going. And of course, as well, the U from the change. That's a curve of change. And that's literally like this. It happens like this. You get to the bottom, everybody says, I quit, I cannot do this anymore. Like many, many resistances come up, but when you overcome this, like the curve, like the U completes. So you get back to the top again. And with better patient-centered, better outcomes, better everything, but you need to get to the curve and you need to overcome this. And so Yolima now is going to talk about the measuring outcomes that is included in this blueprint.
Thank you so much. So inspiring.
Okay. Could you hear me?
Yes.
No? Let's be closer. Sometimes I feel that it's like the expert explaining how to implement value-based healthcare, but it's very far from that. I want to show my point of view because definitely we're trying to implement value-based healthcare, but if I have to raise my hand to say it has been very successful or no, maybe I will do the same face like some of you did. Well, because it's not like a very straight process. It's definitely a process to learn. And what we can share with you is not how to be successful, but how we failed in many ways and how we overcome and how we change and we use this as an opportunity to improve. Then this is the case, for example, of measuring outcomes. So measuring outcomes is very important because, of course, it's the central point of all the equation, is what we are concentrating. Then it has to be some characteristics of these outcomes and how to work with this outcome with the team. So first, how to identify which outcomes is the first question. The second is, how do you make that the people believe that the data is true, that the quality of the data, and I'm sure that you have the same experience when you go to discuss results and indicators with your clinical team or with CEOs or whatever. If the data is good, oh, okay, yes, this is the data. When the data is not good, I don't believe that. There is a little phantom in the IT team that change everything to make it look very bad. So, especially when you do benchmarking. What are doing the other hospital? They are lying in the data. So it's very important that the truthful in the data. Also, to follow the results, to empower because I will share with you also the rate of response of the patient is not very good and you need to do things to improve that, and how do you learn from all the outcomes and identify better practice. So the first thing is how to choose the outcomes, and Maria described that very well. I'm not going to go through that, but basically the clinician had to be convinced that what we are measuring is what is important for the patient as well. Because many times the clinician, I'm a medical doctor as well, then I know what the patient needs. For example, with a patient with breast cancer, many clinicians, there are studies about that, I'm sure that you have been through that. Many people believe, or many clinicians believe that the woman want to keep the breast as the more important thing for them, but when you ask the woman, they want to, it doesn't matter for many of them. They just want to remove all the cancer. If it implies to remove all the breast, it's okay. Then this concept of what is important, what the clinician thinks that is important for the patient maybe is not what is really important for the patient. Then you have to put both in the same point to make this result that you are collecting important for both of them. So how do you make that the data will be truthful? One important thing is standardize. Use a tool that will be standardized. I put this example here. I'm pretty sure that you're familiarized with ICHO. There are another strategies, another way to do that, but it's important that the methodology will be very clear. And if you will participate in a benchmarking, for example, that all the definition will be the same. That is key point for make the people believe that the data is all right, and of course do the adjustment, to do the risk adjustment or the miscase adjustment, to don't hear that no, my patients are different. My patients are more complicated than the patient of the others. So that is why to share the same methodology and standardize that is super important in the methodology. This is how iTunes works. I'm not going to go through. So the other thing is what I say to you. How are we going to engage the patient that they really answer the patient-reported outcomes? If you know, and I think that you know very well, the rate of response for studies when they send patient-reported outcome to the patient, of course, is less than 40%. Then if we're thinking in a methodology that will help us to change the healthcare system, we cannot change the healthcare system with 40% of the response of the people. What happened with the other 60%? Then we need to make that easy for them. This is the first thing. We cannot send thousands of questions. It will be nice to know that. It will be very nice to know that. Go for the minimum that will be important, that they can answer that. Facilitate the way how they collect, and be sure that they could do that in the time. Test that before. But what is really, really important to give the feedback of the patient is make that relevant. It's not in words that you have to fill in a questionnaire of 40 questions, and when you arrive to your doctor say, how are you? Do you have pain? Sorry. 1, 3, 4 hours ago, I answered all these things, and you ask me the same question again. So they need to know that you read that you, as a clinician, that you read that you will take decision with that. It has to be as important as a blood test results. It has to be implicit in the health care of the patient, in the day-by-day care of the patient. Then this is the more important thing to be successful in get these feedbacks. Of course, has to be recommended for the staff. It's not some questionnaire that just arrived. And it's important also that the patient had the feedback. So this is one of the things that we don't have in Valdebrón, but definitely is in our agenda, is when the patient answers all the questions, that they can see what is the evolution, what is her evolution, and what is compared with other patients as well. Because it's always the question, all people have the same feeling, all people recover with this speed, so all these things will help. Also the collecting tool, we also learned a lot in this area. Because we start paying a company, so we see that it was very good, the company was fantastic, and we just implement a stroke one pathway using that. So when we think how we're going to scale up in the organization, it will be very costly. So as a public institution, to like Valdebrón, we basically decide to develop a tool developed by our ITs. Then we start with that, is with an open source, but also integrate all the results with the electronic medical records. Then it allows us to have like the governance in the data, and we can't organize reports and give feedback to everyone without need of a third company. Then it's just a way, it's the message here is that this is possible to organize the tool in your hospital. Of course, we now migrating to a different, we are in a period where this is not using anymore. We change into another one. Then of course, there are, as I say, there are some moments where you want that it will increase, but we are stopping now using that, but definitely it's a good one. If you want that your IT, contact my IT team to understand more about this tool. Is easy to develop as well. So it's important to have the feedback for the individual report, and the doctors have that in the consulting room in real time to give the feedback to the patient. This is one example in a stroke, how we give feedback in the electronic medical records every time when the patient was there to the clinicians. But it's also important that all the clinical team for the meetings that Maria mentioned had the feedback of how are going your patient, aggregate data, and to discuss the quality of the data as well. Because if you don't trust the data doesn't come from heaven, it comes from registers. Then let's see how is the registration, let's see what is the quality of the data, how we can improve that. Then all this feedback about the data is important to have with all the clinicians. So I want to say here as well that collect patient-reported outcomes could be difficult at the start to decide all these things, but there are many outcomes that matter to the patient that are in our electronic medical records. You don't have to start for the more difficult thing if you want just to start using complication, for example. That is important for the patient. The patient wants to know if they're going to have a complication or not, if they're going to recover earlier or not from the illness, then all this kind of thing could be what we call clinical report outcomes. So it's another way to see it. We need to have patient-reported outcome, but also CRON, also clinical reported outcome. Start for what is easier for you. The idea is that the outcomes matter to the patient. So with all this methodology, in stroke specifically, we have a good adherence to the questionnaires. Of course, because the clinician used that in the consultant, and also because they have someone who called the patient when they didn't answer the questionnaire and say, "Hey, you're gonna have in 1, in 2, in 3 days a visit with the doctor. Then you need to fill in this questionnaire because the doctor need to know how are you to decide what to do with that." So with that, we have some results that I didn't present here, but in general, for example, seeing the response for the patient, we reduce 40% of the face-to-face consultation. This is quite important result, especially for the denominator as well, but also because we see that the attention, but a video conference or something was enough to make the patient continue improving the outcomes. So basically, I think that technology could help implementing value-based healthcare, but it's important to make the outcomes a tool for the care management. Thank you.
Thank you, Yolima. How many of you think this is inspiring? Can you raise your hand? Yeah? I mean, you see that value-based healthcare, it's about transparency. And you said it from the beginning, right? We are going to expose also our failures, right? So we can improve. Just like in life, here I think that egocentric personalities have a very tough journey because you have to be very vulnerable to actually show those failures to be able to improve them. It's all about that. It's hard. It's hard, but it's worth. So I think the era of a strategic value-based healthcare, it's gone. It's about implementation and impact. And you see it's happening, right? It's not theory anymore. So thank you for having shared this incredible success story. It's really a success story. I know there's a lot to come. You know, it's face-to-face, right? But this is already pretty unique. There's not many countries that can proud themselves of having such a meaningful examples of real implementation and real coordination of care and patient empowerment. Now, the next question, actually, and it's going into our final phase, it is about public-private partnerships. Because I tell you, no one of the sides can do it alone, right? At the end, it's an ecosystem of people that need each other and need to find ways to work with each other and work towards the common goal, which is actually improving outcomes. And at least there is a very common goal. and a very clear one. So I'm going to ask Belén to actually present one of these also success stories called PIMA. So Belén, the floor is all yours.
Thank you, Carolina. I hope you see my presentation on the screen also.
It would be great to show it while she speaks. Yeah.
Great, thank you. So I'm going to talk to you about PIMA, which is an initiative led by Air Liquide, focusing on sleep apnea patients mainly, once they have been diagnosed with sleep apnea and they go to home. So this is gonna include all the process of care of patients from the moment they receive the therapy. After the diagnosis, they have been communicated diagnosis by their clinicians, and they come to us, sometimes really understanding the disease, sometimes not understanding at all what's going on with them, and asking the question for how long I'm gonna have to use this device. We develop a program to care for these patients using the different concepts of value-based healthcare. I'm gonna go in the concepts quite quick, and if you have questions, we can also see afterwards, but I want to give you the essence of PIMA in the coming slides. So PIMA, sorry, stay in the same slide. Can you go back? So PIMA is first, you're gonna have as a patient an evaluation of self-efficacy and the baseline of how you're feeling in terms of outcomes from a clinical perspective, but also on the quality of life, on your well-being, on your social support, on you as a patient, how's it going? PIMA is going to establish an educational and training program depending on the answers that we're giving before in the questionnaire, which is going to allow for the patient stratification. We're going to have different profiles of patients in a two-axis way, which are going to give the patients specialized care plans for each of these patient profiles. And these care plans are flexible, meaning that one patient, when a situation changes, a condition changes, it doesn't stay in the same line of the pathway. It can go to a different pathway that corresponds to their situation in that moment of life. The therapy is gonna be for as long as the patient needs it, meaning being a chronic disease, sometimes for the rest of the life. The situation and the patient itself is gonna keep changing. And we are also introducing the whole notion of innovative and cost-effective channels. As Carolina said before, the whole notion of cloud care that has been exploding over the past years. When you talk to patients, sometimes they also tell you, we don't want to go to the hospital every 2 months or every X time at these times that are not convenient when we work and everything to have a checkup. Can we do it by digital way or by a phone call, which has existed already for a long time, or by all the other different communication means that exist and that patients want to use because it's more convenient for them. You can go to the next slide. So now what we did in PIMA, we did the whole PIMA model for the patients in Hospital Universitario Central de Asturias, so in the Asturias region in Spain. And all the new patients that were being diagnosed with this sleep apnea went into a PIMA follow-up model. We had mostly men, 75% of them, between the ages of 51 and 70 years. And they all had a level of diploma of high school, at least 43%. The characteristics of the patients were they had a severity of over 30 of 76% of EH, I don't know English. The distance of the point of care, so it was less than 30 minutes for 85% of them that they could go easily to different, like the point of care where we have our places to visit the patients. The technology is of 78% of these patients, and 99% declared to have the support of someone in their families for using the therapy correctly. That gave us different channel profiles for these patients to know for which channel they prefer for us to contact, either through different technologies or for going to visit to the points of care, or if they prefer or they need it, going to home visits, adapting to whatever they needed. And a predicted level of adherence, meaning A, M, or B, as Spanish upper, M medium, and B bajo, low level of adherence to the therapy, adherence and compliance. So we did this in a sample of over 3,000 patients. You can go to the next slide, please. And so what do we do what do we see in the results of these patients that we follow up with this PIMA model? We did it also in an initial phase in a clinical study, to see how the PIMA model was helping comparing to the standard of care for compliance. And we saw that in all the different hospitals that we tested this new method of follow-up for patients, we saw an increase in compliance level. As you can see in the total, we had in the standard of care 66% of patients that were being compliant after a 6 months period of follow-up versus the PIMA model of 80% of patients that were being compliant. And in the graphic in the upper right side of the slide, I know it's kind of small, but what we're trying to show you here is that going from the 30 days to the year of follow-up for these patients, you don't only have an increase in compliance level of the patients, so the dark blue, but you also start to have more and more use of the device. So in sleep apnea, what is recommended by the Spanish Society is to use at least 4 hours per night, 70% of the nights. What we were seeing in these patients is that our population of patients using over 6 hours, 5 and 6 hours of time per night of the device was increasing over the follow-up period, and also the quality of life improvement of the patient. So we are here addressing one of the key complications we have when dealing with chronic disease, patient compliance to therapy. With PIMA, as we are addressing directly and seeing how this patient compliance with therapy is affecting their quality of life and how can we bring both of the concepts together, we are seeing an increase in the compliance level of patients for therapy, which is bringing them all the benefits it brings, but also the patients are declaring to have an improvement of quality of life, which is the graphic in the bottom right. As you see, is going into the green side as the days and passes to the end of the year, 365 days. Can you go to the next slide, please? So what we want to do with PIMA is not only say, okay, yes, we're looking at these results and we're improving compliance in patients for during the period of follow-up, which is, as I mean, for some patients, the rest of their lives. But we also want to assess the impact of having this focus on compliance and quality of life in patients compared to the standard of care in the cost of the healthcare system. And this is the phase we are entering now with this PIMA model, is to say, what is the level of cost offsets achieved through PIMA? For this, we are doing a medical economic study to identify, by improving compliance, how much you're reducing the number of special cases needed, the emergency department visits that this patient have, the days hospitalization, the hospital admissions, the ICU admissions, and the working days missed by the patients. So when we were before talking in the hospital, how sometimes you are working in silos and have to work together with your CFO, we find that in chronic care, we have this other level is to understand how the different budgets are allocated in the healthcare system. Because sometimes bringing some solutions for one section of the hospital is not going to have a direct impact on the whole of the healthcare system and how this is organized. So this is what we're trying to understand also with this medical economical study. Can you go to the next slide, please? Make a long story short, the goals of PIMA, as I said before, is to improve adherence to CPAP treatment, improve the quality of life, to have this better healthcare service, and to improve the sustainability of the healthcare system. So we look into all these areas, trying to measure and see the results of all of these. With 3 groups having this scientific evidence, regulatory compliance with the SEPAR, which is the Spanish Scientific Society, the patient-centric approach, really focusing on what are the patient needs throughout their pathway, which I mean can last long periods in their life, with the 4 key ideas, education and training program with evidence, the stratification and the segmentation, the interviews with patients to find out their self-efficacy with the therapy, and this individual flexible care plan. And can you go to the next slide? And this This just to comment that PIMA was the winner of the Dragons Grant in 2020 for the value-based healthcare. So it's really the focus of Air Liquide, which is in the improving the quality of life patients undergoing the continuous positive airway pressure treatment with the sleep apnea diagnosis.
Thank you, Belén. So you see another very concrete example, also award winner. And we are at the end. We are going to share very quickly one more of these public-private partnerships. And Yolima is going to tell us quickly about it.
Okay, I have the challenge to do that in 2 minutes. Could you hear me? Yeah? So in 2 minutes, just to summarize, this is another public-private collaboration. It's an IMI, Innovation Medicine Initiatives, when we get money from the European Commission, but also from the pharmaceutical companies to develop an observatory of outcomes. So this observatory, without the slide, it's all right. It's not necessary. Yeah. Just that you know that this observatory, we are creating that in Europe. There are 4 countries that also will collect the outcome of inflammatory bowel disease, cancer, and also diabetes. We start with these 3 pathologists. In Spain, we're going to have 1. So this local observatory in these 4 countries would fit the Pan-European Observatory of Outcomes. So just that the name sound to you is H2O, like the water, because like the water, we need the data of the patients, or the data of the patient-reported outcomes to improve and to live healthy in the healthcare system. So if you want to know more about this initiative, I will explain that in deep in another table at 4:30 if you want to know. And I'm not going to stand more.
That was very comprised. Thank you so much. I think people got the idea that the ecosystem is important. So before closure, there's been a lot of content. Not so much discussion because unfortunately we don't have the means, but now is your opportunity to ask any questions you might have. Yes. There's a microphone coming.
Thank you very much. That was very informative and very practical. My name is Jihan Al-Fanam from Oman. I'm quite curious on the selection of the clinical pathway. Did you sort of reach consensus, or how did you decide on the first, clinical pathway? Thank you.
There's always a discussion because I don't know if can you hear me? Oh. There's always a discussion because many teams want to implement value-based healthcare in their clinical pathways. We have this algorithm that helps us select it, but the most the variable that really kicks in the most is the leadership. Leadership is key because they need to lead this. So and that's one of the key points. Another key point is that they ask for it. So it's not it needs to be both sided, board and clinicians, but it needs to come from the clinicians for sure. Because if not, it's going to feel like something, that comes, it's not going to talk about what I want, so they need to feel it theirs. And yeah, that mainly this. And of course, and I'd say, it's not about choosing, but I'd say any clinical pathway that you work on, you need to, bring it with the primary care as well. So there needs to be leadership on both sides.
Thank you.
If I can add something, I think that is always the question, how we will start, and the managers, many times we say, well, we need to save cost. I think that is a mistake, start with this vision. I think that we have to try to have successful stories when we start all this change management. Then what Maria said is the way. Leadership is where we have to focus when we start.
Maybe one quick more question. Yeah?
I would like to know, hello everybody. I would like to know how long is it going to take? Because Vall d'Hebron is one of the main hospitals in Catalonia, but we have several others, not only public, also private and semi-private. So is it going to work with all the hospitals like a pattern? Because you have to change the mind of Spanish people. That's the most important. And then the QAP, the health centers, there is lots of work to do, you know.
But your question is how long it will take to change all the healthcare system in Catalonia, for example? It take long time. Yeah,
Forever.
It's like the curve of everything, like the technology. We start like that, then it will be a point that will be a breaking point, where it will increase exponential. But so far, I think that we are starting this curve. We know in the exponential area, but I think that in Valdebrand, for example, I think that we need another 5 or 4 more pathways that we don't know how long it takes to make all the organization into the...
But did you begin?
The begin is long, depending of how long
you didn't begin yet, or did you begin?
No, yes, we begin,
But only you, like a model, for example.
In Catalonia, do you mean only?
In Catalonia.
There's a couple, Sanjana is doing things, there's people doing it somehow, so there's definitely momentum happening. So, no, thank you for your question. It takes time. I'm going to conclude it here because we have 54 seconds.
Okay, thank you. Thank you so much.
No, thank you. I would like to say the last word, which is, I always tell my team, and it's from Peter Drucker, that the best way to predict the future is to create it. Don't wait for others to create it, because it's a society that depends on your drive to make things happen, right? So you don't have to wait for others to make things happen. You can start tomorrow. You see there's already good ground on driving value-based healthcare. So thank you for the inspiration of the people that have already done it. Yolima, Maria Belén, and of course Air Liquide, for having facilitated this wonderful platform to showcase all this innovation. And I hope you can start tomorrow with something exciting as this. Thank you.